my name is Omar Al-Qadhi. I'm a urologist in the Norfolk and Norwich Hospital and a robotic surgeon. Norwich is a university hospital in the east of England. Many of you probably won't know where Norwich is, but it's in the east of England. We treat a population of between 1.5 to 2 million, and we're a tertiary referral center, so we get all the cancer referrals to our unit. I thought I'll give you some background a little bit about the epidemiology that's, I suppose, specific to Europe, since I work in this part of the world. But some of this Dr. Tam has already talked about, so we may be able to skip through quite a lot of this. In terms of the incidence, it still remains fairly static if you look at the last few years. Worldwide in Europe, we have the incidences reported to be 19 per 100,000 person years in men and 4 for women. So it's less common in women, although we know that women tend to present later and they tend to have worse disease. However, despite that, the mortality still seems to be higher in men. Of course, like Dr. Tamer said in his talk, the majority of bladder cancer is non-muscle invasive. We're not allowed to say superficial anymore, but non-muscle invasive bladder cancer still remains the more common category of bladder cancer diagnosed. And this carries a lot of burden because you have to follow these people up quite a long time, and some of them will require interventions along the way. So that adds to the total cost. And if you look at the EU estimates of costs of bladder cancer, for example, the last ones we have is from 2012, then it's estimated that 4.9 billion euros were spent on management of bladder cancer. So that's quite a lot of money. And risk factors, like we said earlier, for us in the EU, the strongest still remains smoking, the highest risk factor for bladder cancer. And we're still getting a few patients who had occupational exposure, although this is getting less and less nowadays, of course, because a lot of the chemicals used in factories and so forth are becoming very safe. So people are aware of the risks of these compounds produced, but you still see people who perhaps have retired from occupations where they were exposed to chemicals such as aromatic hydrocarbons, presenting with bladder cancer. And of course, in Egypt, perhaps more than other places, there's a risk of schistosomiasis and chronic irritation to the bladder as a result, and bladder cancer resulting from that. So my talk is about the updates in the management of non-muscle invasive bladder cancer. So I think the staging is important to go over again to identify the group of patients that we're talking about. And like you heard previously on the earlier talk, the staging, again, for this probably hasn't changed a lot. In terms of histology classification, well, again, we'll go over that in a minute. But carcinoma in situ and TA papillary tumors and T1 that invade the lamina propria are all grouped together, although they behave very differently in terms of their risk of progression to muscle invasive disease, which is, I suppose, in one way, what we are trying to avoid in the management of these. So like you heard earlier, the 1973 classification is this. We used to say grade 1, 2, and 3. We now try and replace that slowly with papillary urothelial neoplasm of low malignant potential. And this involves a lot of non-cancerous diagnoses, and some of the inverted papillomas, for example, are kind of grouped in this group as well. And this slide just shows you a little bit about the overlap between these two grading systems. So you've got shared grading between 1 and 2 and 3 appearing in now low grade and high grade. And the variant histology, again, I think it's important to repeat this because you heard it in the first talk, but it is of vital importance, especially when we're treating these patients with non-muscle invasive bladder cancer. The pathologists are getting more and more aware of these variant histologies. So you see even the non-GU pathologist that you might occasionally see reporting your pathology will look for these, and they are supposed to report it. I suppose the most common one we see nowadays is squamous differentiation and glandular differentiation. Sarcomatoid, I've listed it as number 3, but actually it's probably one of the least common, but perhaps one of the more aggressive urothelial variants that you would see. And then obviously there are non-urothelial variant tumors. These are the pure small cell carcinomas and pure squamous carcinomas. These behave very differently. So talking about the malignant potential of these non-muscle invasive tumors, like I said, the carcinoma in situ, or TIS, if you look at the molecular pathways that it cause it or lead to the development of carcinoma in situ, they are very different to papillary tumors, and it does have a very aggressive behavior. So it is important to notice when there is CIS, and to note that in addition to other perhaps grades that might be present at the same time. And T1 obviously will have a higher rate of muscle invasion than, for example, TA tumors. So that says that TA tumors are have a risk of progressing to muscle invasive disease in about 5%. So how do we manage the disease nowadays? Well, to be quite honest, the initial management is probably the same as we have been doing for many years. Yes, there are some newer instruments around and perhaps some newer techniques to do a TURBT or a TURB, but the majority of it is actually fairly similar to as it has been for a few years. So we still stress the importance of doing a very good TURBT, and I think that certainly has a therapeutic benefit to a lot of patients. We go back and take more transurethral samples in selected cases, like you heard earlier, and we'll talk about that. And then it's really important to adequately stage these patients. So more and more nowadays, we're using MRI, or MRI of the bladder, to stage patients who perhaps have T1 disease, or whom we think may have more bulkier disease that we haven't been able to sample properly, and it has been very helpful. In the UK, there's a trial underway at the moment looking at doing an MRI of the bladder before your first transurethral resection. It's a long way away from reporting at the moment, but I think the findings from this trial will be very, very interesting. If you compare to what we're doing now, for example, with prostate diagnosis in the UK and a lot of parts of the world, we quite often get a multiparametric MRI of the prostate gland, for example, before we take a biopsy. So in a similar fashion, we're looking at how we can utilize multiparametric MRI, but looking at the bladder tumor, and perhaps coming up with a grading system which is very similar to the radiological grading system, the PIRAD system for prostate, to indicate the likelihood of having muscle invasive disease. So watch that space. So once we've done the staging, we risk stratify, obviously, like you heard, using EORTC scores, or if it's a high risk or high grade tumor, then we can use the Coeto risk classifier, like you saw earlier. And for the day-to-day practice of a urologist, you can get both of these risk stratification tools on your mobile phone. So it's actually very useful to use in the clinic. You can enter the details there and then, and you get an instant result that you can share with the patient, which helps you with your discussion. In the UK, we usually try and get patients through to the multidisciplinary team meeting, which is radiology, oncology, and urology. And it's important that patients go through that to have input from other teams and collectively come together with a plan for that particular patient. And then there's the issue of post-TUR installation of chemotherapy. We'll talk about that when we use single dose and maintenance, and the management of the high risk non-muscle invasive bladder cancer, which is refractory to BCG or intravesical treatment. And it's those groups of patients that usually are the more problematic patients. It's those high risk or high grade non-muscle invasive disease who require long-term management. So like you heard, the TURBT is still very important. It's still the gold standard. We use monopolar or bipolar to use it. In my unit, we have bipolar resection, which makes things slightly easier in certain respects. It's both diagnostic and therapeutic, like we said. And we have to standardize the technique, which is advised by most guidelines. So reporting locations of tumors, etc., like you heard, and resection of all visible tumor if possible. The pathologists always tell us that we should try and reduce cautery as much as possible, which helps them interpret these tumors more accurately. And then taking a separate biopsy with a cold forceps if possible from the tumor base. And this is supposed to give you better muscle in the specimen if you haven't done so already. And then repeating the TURBT, this is obviously for selected cases, the high risk patients that we talked about, but also for patients who perhaps have low-grade disease but have a very large tumor, or patients that that we are unable to complete the resection in one go. So it is quite good to go back and clear these patients if they are going to proceed down the road of non-muscle invasive disease. So you heard the recommendations from the EAU. This is, again, the same thing. In summary, do a bimanual examination. So we try and do this as standard. And then inspecting all the urothelium, including the urethra, and noting any tumors, and try and use a diagram that something looks like that, what you can see on the screen on your right, to indicate where the tumor locations are. And this will help the urologist later on, who may not be you, maybe one of your colleagues who sees them again, to help them with the risk stratification. And then there's Unblocked TURBT. This has been around for a few years now, but it's gaining more and more popularity. You probably see it a lot in meetings, people presenting posters and videos about it. And the idea is to remove the tumor in one piece with its underlying lamina propria, or if possible, the muscularis propria. There are advantages to this, of course, which is that the pathologists are very happy to receive those specimens, because often they get a very good representation of the tumor base and allows good analysis of margins, which I suppose routinely would be difficult to do. It's supposed to have a lower recurrence rate versus standard TURBT. Again, numbers are still relatively small, so I think it's very difficult to make a judgment on that at the moment. They also report having no or very low rates of obturator nerve reflex and subsequent risk of bladder injury. This is mostly when they're using a laser to do these unblocked TURBTs rather than monopolar diathermy. So disadvantages are that it's not really suitable for patients who have tumors perhaps at the bladder neck, or patients who have very big tumors. It's going to be very difficult to do an unblock resection. It's a relatively new technique in comparison to the gold standard, so data are still sort of scarce and compared to TURBT, which we regard the gold standard. And laser devices are not always readily available in all operating rooms, so access to standard TURBT equipment is more readily available. And then one of my concerns with this technique is if you get a deeper resection, you may not be able to give post-operative intravesical chemotherapy, which may have an impact on later recurrence rates. Or at least if you gave it with a hole that you didn't see, then that obviously can carry a risk of extravasation of chemotherapy, and that can have quite disastrous side effects. So I've got a video. I hope you could be able to see it. I'm sure you'll tell me if it doesn't work. This is a monopolar on-block resection of a bladder tumor. You see the surgeon here using what we call in the UK a Collins knife, which is almost like a little hook of some form. And the surgeon here is using a monopolar energy, which is very readily available in most operating theaters. So the first thing they're doing is going around the tumor, which is, as you can see, a very small little papillary tumor on the wall of the bladder, trying to avoid inserting this Collins knife too deep, because it's very easy to go right through into the perivesical fat. And in some respects, this is very similar to what you would do if you were doing a nephroureterectomy and wanting to circumscribe the ureteric orifice. You'll be doing something very similar to this, using perhaps a similar instrument. So here they're using a combination of heat, diathermy, pushing and pulling to try and get this little tumor off. And again, trying to work all the way around and visualizing the strands that are holding it on, and using the coagulation as minimal as possible to try and remove it in one piece. And then you see that they're using a combination of pressure by manipulating the cystoscope, and then that sort of moving the tumor from side to side until they can remove it. So here you could probably see it's quite deep, and it's very easy to go very deep, especially if the fluid installation is on at a higher rate. You can see there is some perivesical fat there, so they've gone through the layer, although this is obviously magnified, and so that in effect this defect is probably quite small. It does demonstrate in a way some of the fallbacks of this technique, and I think using the laser, this is less likely to happen because the penetration of the laser energy is much more controlled. So the lesion is almost off. Here it's just hanging on a thin layer of urothelium. And here it is, the lesion is off. And then you can, quite a lot of these small lesions, you can wash them out through the cystoscope like you would evacuate the tumor chippings. And if it's too big to do that, then you can use a grabber of some form and remove it again usually through the resectoscope or the cystoscope. And then in terms of the adjuncts that are available to us nowadays, again, these haven't changed. You heard Dr. Tamer Hussein talk about the use of photodynamic diagnosis or PDD. Some of the drawbacks of this is you have to install the substance through a catheter about an hour before, and you need specific equipment. It won't work on any cystoscope or camera head, so you need a special attachment camera head to actually be able to use the blue light. And the idea that behind this is that it causes porphyrin or protoporphyrin to accumulate in the tumor, which will then show bright red when you use a blue light. So in the image you've got at the bottom of the screen on the left is carcinoma in situ with typical white light, and on the right it's with the blue light switched on, you see the carcinoma in situ lighting up pink. So higher sensitivity for detecting exophytic tumors as well as carcinoma in situ. It's been shown to have a longer recurrence-free survival when this is used for follow-up for patients with superficial or non-muscle invasive bladder cancer. There are obviously drawbacks to this. Again, in addition to the fact that it's not readily available, it can give you false positives for patients who have recently had BCG or a recent urinary tract infection. Narrowband imaging, again, I'll skip over this very quickly, but this is more readily available. It doesn't require installing substance into the bladder, and it uses specific wavelengths that are absorbed by the hemoglobin, and therefore the blood vessels are much easier to see, and tumors subsequently are easier to see as well. In the lower image, you can see a white light cystoscopy showing some tumor, and then the same image with the narrowband imaging switched on, showing the tumor a bit easier. And then there's a newer thing around, which is again fairly new. It's the Storz Professional Imaging Enhancement System, or SPIES. This is a software enhancement mechanism that basically tries to sharpen the images. It manipulates the color wavelengths, and it uses a special algorithm to do that. I don't know whether you can see the picture very clearly via the internet, but if you can, these two pictures side by side, each picture on the right is the clearer or more sharp image, so it helps visualizing the tumor. And then we come to, after resection of the tumor, to do the EORTC score, and I agree entirely with what was said earlier, that it's very important to do this each time we resect a tumor. And a lot of the follow-up of these patients who come for cystoscopies is done by a lot of our junior doctors in urology, and it's very important for them to know what the background is for each patient when it comes. So we try and summarize for each patient when we write a letter or summarize their treatment management on electronic records. We try and indicate some form of EORTC risk scoring, which will hopefully help them decide the future follow-up plan, and also whether the patient needs to proceed down a different treatment route. I'm not going to repeat this because you've already heard it. And then, of course, the Coeto criteria for high-risk non-muscle invasive bladder cancer. So what about the single post-TUR BT installment of chemotherapy? For the UK, at least, this is standard practice. It'll be interesting to hear from you what your practice is in Egypt and how you feel about this. But we certainly try and give it routinely nowadays. There was a meta-analysis more than 10 years ago now by EORTC, which included 7 randomized controlled trials and almost 1,500 patients. The majority of them had low-grade disease, and stages were between TA and T1. The primary endpoint for this analysis was looking at the recurrence rate, and that's where they came with this 39% reduction in relative risk. And the absolute risk reduction is about 12%. And if you look at the number of patients that you need to treat to achieve this benefit, it's about 8.5 or 8 patients to achieve to prevent 1 recurrence. And those figures are regarded as quite good. In all the trials, the drug was given within 24 hours, and in 6 out of these 7 trials that are included in this meta-analysis, the treatment was given, the intravesical treatment was given within 6 hours, and doesn't appear to be any difference in the efficacy of Mitomycin C, which is what we use in the UK a lot, to epirubicin or doxorubicin. In my practice, I give it while the patient is still in the operating room at the end of the TUR. If there is no contraindication to it, and my criteria is like many in the EAU, if there's heavy hematuria, or if I've suspected there's a deep resection or indeed a perforation, then I would try and avoid giving it. But if not, then I'll give it through a catheter at the end of the procedure while the patient is still under anesthesia, and I'll clamp the catheter off. The patient will go to the recovery area and then have his mitomycin drained an hour later and the catheter removed if the urine is clear. And we're trying to increase the number of patients who can go home the same day after transurethral resection. In terms of what's new regarding the single installation post-surgery for post-TURBT, there's this paper that came out in JAMA last year about using gemcitabine instead of mitomycin, I suppose. It's a randomized controlled trial that looked at just over 400 patients with superficial or non-muscle invasive bladder cancer. They end up recruiting less number because the criteria they used to select patients was based on cystoscopic view. So if the surgeon felt this was looked like it was low grade, then they got enrolled. So as you can imagine, there were a few patients that were removed from the trial because they had higher grade disease. But regardless of that, they had almost 200 patients in each arm, and it was randomized to gemcitabine versus saline 1 hour after TURBT. And they did cystoscopies and urine cytology on them for 2 years. And in the pure low-grade tumors, the 4-year estimate of recurrence was 35% in gemcitabine group versus just over 50% in the saline group. So it's an alternative that's certainly valid. And then the issue of risk stratification. This is extremely important, I think, and I would agree with the previous talk that it's important. It doesn't matter perhaps what classification system you use, whether it's AUA or the European classification. I think the European one is probably more prevalent and certainly something that I use in my practice. The UK-based classification system is very similar, which I'll come to show you in a minute. And in here we know that low-risk tumors are those that are small, solitary, perhaps mostly TAG1 tumors. And then the highest risk tumors are T1s and the high-grade or G3 tumors, and everything else in between is intermediate. So it's fairly straightforward. And then you have a subcategory, like you heard earlier, of highest risk disease, and those are the ones that we need to watch out for because they probably would do better with having a cystectomy either as a primary option or alternatively if they fail BCG and they develop and become in this highest risk category, then they probably shouldn't continue with BCG, for example. This is from the National Institute of Health and Care Excellence, or NICE, which is our body in the UK, and it's very similar in many respects to the EAU classification or risk stratification. So for a low-risk tumors, these are the easy ones to manage as part of the non-muscle invasive bladder cancer. There's nothing new, I think, that's developed here in the last few years in the management of this class of, or this group of patients. So the first management, which is a TURBT that we will do to diagnose the disease and then classify it into low risk. And then hopefully a lot of these patients would have received a single dose of intravesical chemotherapy. So those patients will not need anything else other than cystoscopic follow-up. The EU recommends 3 months, 12 months, and then every year for 5 years. A few years ago, our guidelines in the UK changed, and now the recommendation is for this low-risk group is that we discharge them after 12 months. So then there are urologists here that don't really agree with that, and they keep their patients for follow-up longer term. I think either way, there seems to like the evidence is relatively weak as to the duration of the follow-up. The intermediate risk groups, these are the recurrent small multifocal cancers that are less than 3 centimeters or one single more than 3 centimeters, and these will often recommend they have 1 year of intravesical chemotherapy. We tend to use a lot of Mitomycin maintenance here for this category of groups, or this category of patients. But obviously BCG is a very valid alternative. And then cystoscopic follow-up is slightly different between us, perhaps in the UK and the EU, but not very much. And then the high-risk non-muscle invasive bladder cancer, again, this is probably the more challenging group that when you see them in clinic, you'll probably see them a lot for follow-up and then down the line, perhaps for disease recurrence or progression. And it's really important to pick out at the outset, at the beginning, those patients that might do better with radical cystectomy. And I suppose being a cystectomy surgeon myself, I suppose I'm a little biased towards primary cystectomy, but I have offered it a lot to patients who I felt had a very high risk or fell into the category of highest risk. So it's important that the patients who fall into this category see a surgeon perhaps who does radical cystectomy procedures to talk to them about that option. Regardless, it's majority of these are T1 tumors or carcinoma in situ with a combination of high-grade lesion. And also the multiple recurrent low-grade ones that are also big in size. So those fit into the high-risk category. So initial TURBT, we talked about getting an MRI of the bladder as part of staging. And we are seeing more and more of these nowadays, and MRI is quite useful to tell you the disease burden. And then we recommend usually intravesical BCG for 1 to 3 years. We try and give them 3 years wherever possible, but we know that the dropout rate from BCG after 1 year is actually quite high. But if you manage to get 1 year of treatment, then it's usually quite beneficial. Once they finish their BCG, we have quite tight cystoscopy follow-up for them. And then there's the issue about upper tract imaging with CT. Some units would recommend doing a CT every year, but like you heard earlier in the talk, that carries a radiation dose. And again, sort of picking out the patients that would require this is probably more important based on individual risk stratification, perhaps. So the maintenance intravesical treatment, BCG is still pretty much the mainstay of treatment for these patients. We give it, as we said, in a schedule for 3 years, and the schedule is usually the same as you'll find in most places, and it's based on the data from Sylvester and Lamb. So the EORTC, the data that you see there is for almost 5,000 patients who were randomized or looked at in terms of BCG versus TUR and other immunotherapy, 24 trials in total, with up to 3 years of follow-up almost in median. A lot of these tumors were papillary in this group of patients. Carcinoma in situ was less common, less prevalent in that group of patients that he looked at. but there is basically a 27% reduction in the odds of progression when maintenance BCG was used. And Bohl and Bock in 2004 looked at BCG versus mitomycin. And again, this was 9 trials, 5 had mitomycin, 4 BCG, almost 1,200 in each arm, with a median follow-up of just over 2 years. And there's a reduction in risk from 9.4 to 7.7 with maintenance BCG, and reduction odds overall of recurrence is about 23%. So the schedule we talked about is 3 weekly installations, 3 months, 6 months, and then 6 monthly. And we give them an induction course of 6 doses to begin, 1 a week at the outset at the beginning. And this three weekly installation pattern is based on experimental evidence showing that urinary cytokines were at peak level at around 3 weeks. And that's where that came from. The duration of 3 years was from LAM, and that's what this SWOG trial reflects. It's almost 400 patients treated with BCG maintenance for 3 years versus induction BCG. You find that there's a difference in the overall 5-year survival of 83% favoring the maintenance arm. But if you drill down into this data, you actually find that quite a few of the patients were unable to complete the 3 years, which is interesting. And then we have the issue of the BCG failure and the terminology used, and that's gained a lot of, or it's become in the spotlight recently, because a lot of new trials are trying to look at this aspect of urology, the BCG failure group, which is a problematic group. But if you look back at the data, perhaps running up to 2015 or 2016, the trials that included patients with BCG failure were a mixed bag of definitions. So we have people who perhaps were intolerant of BCG and didn't complete BCG properly because of side effects. And you have the other extreme of those with the patients who perhaps had recurrence or progression of high-grade disease despite having adequate amounts of BCG. So there is a move towards trying to standardize the terminology, and that's what the EAU recommends. So the BCG failure includes several things. So BCG refractory disease are those persistent high-grade disease at 6 months despite adequate BCG, and also includes any upgrading or upstaging at 3 months after induction BCG. And then you have the relapse, which is the recurrent high-grade after achieving disease-free state for 6 months. And again, those have to have had adequate BCG treatment. And you have an unresponsive group, which is a combination of the two in a way. And then the non-tolerant group, which develops side effects. So in terms of recommendations from the European Association of Urology, you can see from this table that radical cystectomy is still the recommended option for these high-risk tumors once they've failed BCG for whatever reason. But there is a slight difference between the timing of this failure or relapse, if you like, and there is option to challenge patients with further doses of BCG in certain situations. And again, the importance here is to really pick out the ones that are going to do well from those that might do badly, to counsel them appropriately. And the other problem, of course, is quite a few of these patients that you see in the clinic to have a discussion about their recurrence. They're not really fit to have radical cystectomy. So those patients are in a bit of a problem group because they can't have radiotherapy because it doesn't really work for this category of patients, or doesn't work very well. And if they are very high risk of having a cystectomy, then your other option is to re-challenge them with more BCG, or alternatively go down the route of clinical trials. So indications for radical cystectomy in this non-muscle invasive bladder cancer group is BCG failure, like we talked about, and we mustn't forget that you could use it as a primary option for the younger patient, or perhaps for certain select groups that we'll talk about. And then the highest risks category are those that have a combination of high-grade T1 tumors with carcinoma in situ, or those who have carcinoma in situ in their prostatic urethra, those who have bulky disease of T1, multiple large tumors, and again, those who have lymphovascular invasion or variant histology. And radical cystectomy for high-grade non-muscle invasive bladder cancer is a good option. And it's important to remember that up to a third of patients who have not had any treatment are upstaged to T2 disease or more at cystectomy, when it was previously thought to be T1. And in BCG failure, the 5-year survival is still actually very good compared to, for example, radical cystectomy outcomes for muscle invasive disease, for T2 disease or T3. Even if they fail BCG, their odds of being cancer-free are about 90%. This is only, of course, if the disease is truly T1. If it becomes muscle invasive after cystectomy, their outcome tends to be slightly worse than those who present initially with muscle invasive disease. So primary cystectomy for these high-risk patients, as we said, selected cases, perhaps the ones who have severe lower urinary tract symptoms, small contracted bladders, they won't be able to tolerate intravesical treatment. And more with the presence of MRI, we're seeing patients present with high-risk prostate cancers, and those patients sometimes prefer to have a cystoprostatectomy, for example. In terms of how well they do, we said that some patients have extravesical disease even at cystectomy. In some reports, up to 43%, and even node metastasis in about a quarter in some reports that you can find online or on PubMed. The 5-year progression-free survival, as we said, exceeds 75%. And in one paper, they looked at the recurrence at 10 years, and the recurrence-free survival in 10 years is reasonably long for these patients. It's about 79 or 80%. Of course, the drawback of primary cystectomy is the morbidity associated with the urinary diversion and the surgery itself. But we find nowadays, with the use of robotic instruments and enhanced recovery pathways, that the complication rates have gone down. And if you look at the number of complications that require a form of intervention, whether that's radiological or under general anesthesia, those risks have gone down, and it's reported that almost 20% of cases may require something like that. And of course, in younger patients, you would be more thinking about the continent urine diversion, what their sexual function like and might be like afterwards, and the quality of life. This is the patient that I chose as an example to promote the idea of robotic cystectomy, I suppose, with this group. He was a 70-year-old man who had radiotherapy for prostate cancer a year before he saw me. And he presented with T1G3 disease and carcinoma in situ. Of course, they didn't favor doing a primary cystectomy on him first, so they gave him BCG. So he managed to have an induction course and then first dose of maintenance, and then he reoccurred at T1G3, and he didn't want to carry on with BCG. So we had a conversation with him. He was quite willing to go down the route of cystectomy. So we had the robotic procedure with an intracorporeal urinary diversion using the enhanced recovery protocols, and he was home at day 6, and he'd done very well. He gave me the permission, by the way, to use his photograph. So if primary cystectomy or salvage cystectomy is not an option, then maybe one of these might work. We're using these a little bit more than we used to, the device-assisted intravesical therapy, and they fall usually in 3 main categories. It'll be interesting to hear from you and the audience what your experience is with using these. But microwave-induced hypothermia is one, hypothermic intravesical chemotherapy is the other one, and electromotive drug administration, or EMDA. And all these 3, what they try and do is either they increase the heat of the tissue in the bladder, they increase the heat of the substance itself, such as the mitomycin, or they use electrodes on the outside of the body to use an electrical current. And the idea is that you increase the permeability of the chemotherapy into the bladder wall. So the first one is microwave-induced hypothermia. This is a special catheter. You need a special device, which you can see a diagram of on the right of the screen. And this trial that looked at using this is in 160 patients. 80% of those had failed BCG. And so basically you place a catheter which has a transducer and a thermal regulator attached to it. And in a similar way, as opposed to giving BCG or other or Mitomycin, 6 installations each time. And the recurrence-free survival was reasonably good at 60% at 1 year, and it falls to about 50% in year 2. But only 4% of these patients developed muscle-invasive disease, which is reasonable. The second one, again, you need a special device. This is what we have in my practice, and we have some experience in using it, again, in a few selected patients who are not really fit for radical cystectomy or may have tried BCG for multiple superficial or non-muscle invasive disease of low grade, but keep getting a lot of recurrence. And they failed intravesical mitomycin, perhaps failed intravesical BCG, and coming up to the third option, we may use that. And it's a closed system. This heats the actual mitomycin itself. It has a special pump that keeps it at a certain flow rate and pressure and maintains a high temperature of about 43 degrees. There is a publication from Sousa and his colleagues in the International Journal of Hypothermia, and they looked at 40 patients altogether. However, 24 of these patients were actually given this stuff before the first TURBT. So they were looking at whether they could use this as a chemoablative procedure. Anyway, 16 of them were post-resection, and they found the recurrence-free survival was 87% in 2 years. And then we have electromotive drug administration, or EMD. Again, this has been used for various applications, and somebody thought they could try this with bladder installations. And this paper looked at BCG versus BCG in combination with electromotive mitomycin. And as you can imagine, the ones who had BCG and electromotive mitomycin did better. They followed them up to almost 90 months. And the ones that had sequential BCG and electromotive mitomycin had a better interval of free of recurrence of up to 69 months versus 21 months. Again, it's a special catheter that you have to place, which has an electrode in it, an active electrode. And then there are little plates that you place onto the body in a similar way, I suppose, to a diathermy machine in certain respects. It's a very small electrical or some very weak electrical current of 20 milliamperes. And then we sort of look into the era of immunotherapy, and this is now coming into the non-muscle invasive bladder cancer, to the high-risk disease. So the immunotherapy is mainly the PDL1 or programmed death ligand 1 and programmed death 1 or PD1 checkpoint inhibitors, and these are expressed on tumors. The PDL1 at least is expressed on tumor, and it binds to the PD1 receptor on T cells. Of course, you all know this has been exploited for muscle invasive disease, and it's been FDA approved in the relapsed local recurrence or metastatic urothelial cancer in patients who have not responded to platinum-based chemotherapy. So in certain respects, these checkpoint inhibitors release the brakes and allow the immune system to target the cancer cells. There are a number of trials that are now recruiting. Some of them are almost closed and some of them are finished, nearing reporting. But they've looked at using these checkpoint inhibitors as single agents or in combination with other therapy, which is mostly BCG. And one of the more common or one of the older agents is atezolizumab, which is again one of these checkpoint inhibitors that was used in locally advanced bladder cancer or metastatic bladder cancer. And it's a phase 2 trial that's almost finished, looking at using this in BCG failure. And there are others that are using it in carcinoma in situ that's refractory BCG. and then combination arms looking at mostly at the moment the toxicity levels and tolerability in combination with BCG. And as you can imagine, the side effect profile is going to increase quite significantly, although this hasn't been shown so far. One would expect that BCG in combination with immunotherapy might be problematic for more patients. And then one of the newer techniques, I suppose, that is vaccines. Again, you've heard of vaccines being used in prostate cancer. In a similar way, they've investigated using vaccines here. There might be some apprehension amongst researchers nowadays with the coronavirus to go down this route again, but there's certainly ones that have been shown to work. And one of this is PanVac, which is a pox virus. And this contains CEA and mucin-1 proteins or molecules, and these are very highly expressed on bladder cancer cells. So 93% for mucin-1. So this causes selective destruction of tumors. And they're looking at a trial of combination of this with BCG versus BCG alone, and the results are looking actually quite encouraging. The second one is the heat shock protein type technology it's an allogenic whole cell vaccine, HS41 or HS410. And this is a slightly different mode of action. Again, primes the immune system to attack the tumor. And again, this is a trial looking at a combination of BCG versus BCG alone. So far, the recurrence-free survival seems to be the same, but those patients on the vaccine arm have all shown almost all have signs of response to immune response to the tumor-associated peptide. So there is some sort of initiation of the immune system that genuinely works. And then gene therapy, I suppose, is the final bit, and this utilizes the natural differential expression of certain genes during tumor, or suppression, for that matter, of certain genes during tumor development. And one of the more common ones is H19, which is an oncogene, and that's suppressed in the adult human bladder. It's overexpressed in a number of tumors, ovarian cancer, testicular cancer, but also in up to 85% of bladder cancers. And the BC819 is a recombinant DNA plasmid that carries a gene for diphtheria A, which is under control of a H19 promoter. So when you inject this into the bladder, it will target this areas of increased expression of H19, one of which obviously is now bladder cancer, and this will result in selective destruction of the tumor. Several trials ranging between phase 1 and 3 are underway to try and investigate this, and it's shown a lot of promise. And so in one of the trials where they gave this intravesically, they resected the tumor and they left a very small, tiny portion of it, up to like maybe 0.5 centimeters. And they used that as a marker tumor, and they looked at the efficacy of the drug getting rid of the tumor completely at subsequent cystoscopy. And they found, interestingly, that 22% of the patients, the tumor had completely gone when they looked back in 3 months' time. And in about 50% of them, the tumor had shrunk by half. So it does seem to work, but the trial is still going. So in summary, I must apologize, I've talked for maybe longer than what I was intending to. And I had a bit of overlap with the previous talk, but non-muscle invasive bladder cancer is a really challenging group of patients, and they have a high burden of resources, like we said. We must stress the importance of adequate staging and risk stratification, because that will pick out those patients that are more likely to do better with perhaps cystectomy earlier rather than later. And despite all the newer techniques I have perhaps talked to you about today, radical cystectomy is actually the gold standard for cases who failed intravesical BCG and have high risk non-muscle invasive bladder cancer. And we should always remember to get patients seen by a surgeon who perhaps can offer this as an option. New therapies are on the horizon, and I think personally the immunotherapy checkpoint inhibitors will certainly will play an important role in the next few years to come. I must say thank you to you all for listening to me, and thank you for the organizers for hosting this. You must be really all congratulated for pulling these webinars together. We've lost all our traditional meetings now because of coronavirus, but you've embraced technology and you brought us all together. So thanks again.